Hello, everyone. Happy New Year. Merry Christmas. Welcome back to the TradNurse Podcast, the spot where we talk real nursing, no filter. I'm Christine, your host, and today is January 7th, 2026. This is episode 20. And something big just dropped on all of us in healthcare. Picture this. You finish a brutal 12-hour shift. You're charting and it's 7:30 p.m. at night because you had 7 patients instead of the staffing ratio of med-surg 5-1, and your nursing assistant called out. And you're wondering if you missed something because the floor felt unsafe. We've all felt that. For years, we've screamed that safe staffing saves lives, and hospitals have treated it like a budget line till now. As of January 1st, 2026, that was literally 6 days ago, the Joint Commission said, not anymore. They just elevated nurse staffing to a full-blown national performance goal. If you go to their website, it is Goal 12. This is historic, I know. Don't get too excited. We hear these things, but this is a big thing. The American Nurses Association called it a celebration of what nurses have fought for. The AACN said it's finally recognizing staffing as core to patient safety. If you don't know what the AACN is, that refers to the 2 major nursing organizations. The American Association of Colleges of Nursing, which sets the standard for nursing education, and the American Association of Critical Care Nurses, which focuses on advanced practice and critical care nursing, offering certifications like the CCRN, and both are very influential. But the Colleges of Nursing is the national voice for academic nursing. Critical Care Nurses Organization supports acute critical care specialists and their patients. So today we're diving deep. What does this actually mean? Will it change your shifts, your staffing ratios, who you work with? Is this real progress or just more paperwork? Let's unpack it. First, quick context. The Joint Commission used to have National Patient Safety Goals, the NPSGs. As of January 1st, 2026, they replaced that chapter with National Performance Goals, NPGs, as part of their accreditation 360-degree overhaul. They cut over 700 redundant standards to focus on what really matters, which is measurable, high-impact stuff. And right in the middle is the MPG goal, number 12. Which states the hospital is staffed to meet the needs of the patients it serves. And staff are competent to provide safe, quality care. Yes. Nurse staffing is now explicitly a national accreditation priority, not just a suggestion. And hospitals have to prove it during surveys. So what do hospitals actually have to do now? Here's the breakdown from the official requirements. Adequate staffing levels. They must show they have enough qualified staff, especially RNs, based on patient acuity, not just some arbitrary grid or a staffing scheduler who's just calling in extra hands. These are acuity tools, predictive modeling, and they need evidence. There also needs to be 24/7 RN presence. A licensed registered nurse has to be on duty at all times to provide care or supervise it. And this hits critical access hospitals. It's more for them. The nurse executive in charge, that's your chief nursing officer, CNO, or the designated nurse leader. In some places, it could be the house supervisor role. They have to lead the staffing decisions. It's not just HR alone and not finance, your chief financial officer or your CEO. In these smaller hospitals, they make the staffing or the hiring decisions based on staffing. And I've heard, just so you know, I've heard CNOs say, sorry, I don't have it in the budget, or my hands are tied. Only HR allows me to hire new staff. This changes that. You do have more power here and you need to use it. Also, competency checks, ongoing training, skill validation, fixing gaps, no more throw them in and hope for the best. This is how hospitals tend to operate. You've noticed cuts in education, things are just online, just watch some videos. That I don't think is going to cut it. You have to make sure that your staff are trained and can do the job, and that education should be consistent. Also, collaboration and plans, written staffing plans, like you do patient care plans. These are written staffing plans that must be followed and documented. HR will know your plan, the nursing team, the administrative team, and the charge nurse team. Any surge response, how will you do that? If the ER is high sensitive, high acuity, and med surge is not at that acuity, can we float an RN down to the ER? Those will be decided ahead of time so that all of the charges and the house supervisor know what the plan is. Is there low census? Can somebody float to med surge? Med surge, what is the plan? And that will be documented and across all of the teams. And this builds on Medicare rules, but now it's scored. You fail this and you risk accreditation and reimbursement hits and bad publicity. Okay, so is this a win? Absolutely. It's validation. Nurses have said for decades, understaffing kills. Let me say that again. Understaffing kills. Studies link it to higher mortality, more errors, burnout, moral injury, staff turnover. The Partners for Nurse Staffing think tank has pushed this for years. The American Nurses Association and the AACN cheered it when it was announced in the fall of 2025. But let's be real, there are skeptics. And many of us who've worked on the floor are asking, where are the hard ratios? 1 to 5 on med surge, 1 to 2 in the ICU, and it needs to be managed that way. How many times have you had a 6th patient? Oh, we have a new admission, a 7th patient. It happens, but should it happen? It's not there yet. It's adequate and it's based on needs, which means hospitals still have wiggle room and enforcement depends on surveyors and paperwork could explode. However, it does come back down to how are the hospitals managed. So I want to hear from you. Has anything changed on your unit since January 1st? Do you hear managers suddenly talking about acuity more? Or is it just business as usual? Drop a voice memo or an email, and we'll feature some real stories next episode. From the frontline perspective, this could give leverage to the nurses. Next time you say, this assignment is unsafe, you can point to goal 12 from the Joint Commission standards. Shared governance committees might get more teeth. If you don't have a shared governance committee, start one. But if hospitals just slap together a policy without investing in bodies, we'll see right through it. Now, let's flip to leadership. I've been in that role. Your chief nursing officers and your nurse managers should be scrambling this week, auditing their plans, updating their acuity tools, and strengthening their human resource ties. Some are using NDNQI data or acuity software to prove compliance. Others are recruiting harder or rethinking their float pools. I've seen this. I've seen this in Florida. If you're in a leadership position, this is your moment. Push for real investment, better pay, retention bonuses, flexible schedules. That's a big one for me. Flexible schedules. Because the mandate is here, but the shortage isn't going anywhere. So looking ahead, our future outlook segment here. Could this pave the way for enforceable ratios? Some states already have them. Maybe a national pressure builds, or will it stay vague? Either way, its progress. Safe staffing isn't optional anymore. It is a performance goal tied to accreditation. So, key points to include here: the potential for stronger enforcement. Right now, Goal 12 requires hospitals to prove adequate staffing based on patient needs using acuity tools, plans, etc. But it doesn't mandate hard numbers. For example, no required 1 nurse to 5 patients ratios on med-surg or 1 to 2 in the ICU. So that will surveyors get stricter over time? Could repeated non-compliance lead to heavier penalties? And then the pathway to enforceable ratios. Many states like California already have mandated ratios, and national advocacy groups, the ANA and the AACN, have long pushed for them. So Goal 12 is seen as a stepping stone. It's a mindset shift, as staffing agencies and experts call it, that elevates staffing to a core accreditation issue. The outlook teases if hospitals struggle to comply or if data shows better outcomes, it could build pressure for federal or broader mandate ratios in future Joint Commission updates or even legislation. The broader mindset and policy shifts highlights how this could encourage investments in retention, better pay, flexible schedules, more use of predictive staffing technology, or even national discussions on fixing the shortage. It's framed as progress, but the work isn't done. Will this keep it balanced? I acknowledge it's not guaranteed, but could this pave the way? It's a historic change. It's an advocacy win for nurses after years of pushback. Why this is taking so long, I don't understand. So nurses, know your rights, read your hospital staffing plan, speak up in your meetings. This is our win, but we have to hold them accountable. Thanks for listening. If this episode hit home, share it with your unit. Let's get the conversation going. Drop your thoughts, stories, or guest ideas. Next week, we're tackling even tougher issues: AI in nursing, the future of nursing. Until then, take care of yourselves out there because patients need us strong. This is Christine. This is the TradNurse Podcast. You can connect with me on social media across all platforms at TradNurse. Stay safe, stay loud.